Hello, everyone. I am Dr. Mehmet Copuroglu, and I am working on the Kayseri City Hospital in Turkey. And I would like to speak about surgical approaches in ectopic pregnancy, effectiveness, complications, and long-term outcomes. First of all, ectopic pregnancies remains a significant cause of maternal morbidity and, if untreated, unfortunately, mortality. It occurs when a fertilized egg implants outside the uterine cavity, most commonly in the fallopian tube. Surgical management continues to play a crucial role in treatment, especially in case of tubal rupture, hemodynamic instability, or failure of medical therapy. This presentation, I want to explore the effectiveness, complications, and long-term outcomes of different surgical approaches in ectopic pregnancy and clinical decision making. First of all, what are the risk factors of this ectopic pregnancy? First of all, and the most important thing is the previous ectopic pregnancy. Pelvic inflammatory disease, tubal surgery or sterilization, assisted reproductive technologies, and smoking and advanced maternal age is the risk factors of the ectopic pregnancy. For clinical presentation, how can the patient, how can the woman come to us for the hospital? The first thing is abdominal or pelvic pain. This pain is really harmful and really harsh, and vaginal bleeding, amenorrhea, and what of the rupture of the tubule? It's signs of the hemodynamic instability, hypertension, tachycardia, and syncope. Emerging situations are hemodynamic instability, tubal rupture with intra-abdominal bleeding. What are the contraindications for medical therapy? The medical therapy is methotrexate. If the methotrexate is not suitable, for example, liver kidney dysfunction or breastfeeding is the most important things for the contraindications. Failure or medical management. Rising or pleasured beta HCG after methotrexate. The large ectopic mass or high beta HCG levels, the tubal or mass higher than 3.5 and 4 centimeters, and beta HCG higher than 5,000 milliliter. Preference for different treatments enabled to add regular follow-ups the patient's specific factors, and our surgical goals are hemostasis, removal of ectopic tissue, and fertility preservation when possible. Surgical options, salpingostomy versus salpingectomy. It's very different. Maybe the words were synonymous, but the management is really different. Salpingostomy, linear inclusion made in the fallopian tube to remove ectopic tissue. Tube is preserved. This is very important. For the salpingectomy, we cannot preserve the tube. These are some advantages: preserves fertility and minimally invasive. Usually, laparoscopy in our hospital we use generally laparoscopic, but many substances do. Maybe we use the laparotomy, the big one. Disadvantage of risk of the person trophoblastic tissue. It's very important and requires beta HCG follow-up and until detectable. What are the salpingectomy? Salpingectomy is advanced because of the lower risk of person trophoblast, no need for prolonged and beta HCG monitoring. Unfortunately, permanent loss of one fallopian tube is the most important disadvantage. Laparoscopy versus laparotomy. Laparoscopy is, in my opinion, more beneficial than the laparotomy for the patients because of the our seizures are very little. First line approach is the most stable patients, less postoperative pain, shorter hospital stay and faster recovery, reduced adhesion formation, and better cosmetic results. But you have to be the skilled surgical team and equipment. If only you are not the very well, because of your team has to be really and really skilled because of this. Success rates, both salpingostomy and salpingectomy have high immediate success rates in resolving ectopic pregnancy. Salpingectomy is definitely with nearly 100 percent resolution. Salpingostomy has a 5 to 20% of risk of persistent trophoblastic tissue requiring further treatment. Recurrence risk of the recurrent ectopic pregnancy similar between both procedures, 10% to 20%. Condition to control the tube, timing, type 2 showing is very important for us. Intraoperative and postoperative. Intraoperative complications, bleeding, the most important thing, especially during salpingostomy or in ruptured ectopic cases. It can be very harmful, so we have to be very careful while we are in the operation. We always check ourselves, and the anesthesia team will always check ourselves too. Conventional laparotomy, postoperative complications, infection, the wound infection, for example, the wounds are very specifically, unfortunately, pelvic abscess, more common in open surgery, adhesion formation, and persistent trophoblastic tissue. Impact on the future fertility. Salpingostomy versus salpingostomy. A healthy contralateral tube is similar between both procedures, but salpingostomy may slightly improve fertility chance in women with compromised or absent contralateral tube. Recurrent ectopic pregnancies. When I talked about the first of my explanation, very important, the most important risk factor for the ectopic pregnancy. So recurrence risk 10 to 12%, 10 to 20% after any ectopic pregnancy. Factors affecting fertility, condition to remaining tube. In salpingectomy, unfortunately, we take the one of the tube because of the rupture, but salpingostomy we cannot that one. Role of assisted reproduction. A woman with bilateral tubal damage or recurrent ectopic pregnancy may require IVF for future fertility. Long-term outcomes. Reproductive health. Most women can achieve a successful intrauterine pregnancy after surgical treatment of ectopic pregnancy, because of you have the most of women have two tubules, and so if we take one of them because of the this illness, the other one is fortunately it's very good effect on the outcome, the long term, and most women can successfully enter pregnancy. And fertility outcomes depend more on underlying tubal health and the surgical technique itself. Recurrent ectopic, I say again and again, occurs 10 and 12, 10 and 20 of percent cases after one ectopic pregnancy. So what about psychological impact? Unfortunately, ectopic pregnancies can have lasting emotional and psychological effects. Common issues include anxiety, grief, and fear in the future pregnancies. Psychological support and counseling are beneficial for long-term well-being. In our hospital, we use and we always consulting the psychological professions. Chronic pelvic pain and adhesions, more common of after open surgery, laparotomy, ruptured ectopic, and can negatively affect quality of life and fertility. Comparison with medical management. What is the medical management? Medical management is a methotrexate. Methotrexate is the very common in the before the surgical management. If we have small ectopic mass lower than 3.5 centimeter, no fetal activity cardioid, and beta helical levels typically smaller than the 5,000, it is very useful. What about these advantages? It is non-invasive because of medical, no anesthesia nor surgery required, so no bleeding or no the operation swellings. Preserves fallopian tubes in the most cases. And what about the limitations? Close monitoring beta HCG levels, risk of treatment failure up to 15%, long resolution not suitable for all patients. What about the surgical management? The advantages: immediate resolution, useful emergency, and direct visualization of pelvic organs. What are the limitations? Invasive and risk of complications such as bleeding, infection, and adhesions may affect fertility depending on procedure. Current guidelines and recommendations are ACOG, the American College of Obstetricians and Gynecologists, recommends methotrexate for stable, it's very important, stable patients who meet criteria. Surgical intervention is advised, hemodynamic instability, suspected ruptures, and congenital failure and medical Treatment. Royal College of Obstetrics and Gynecology, what's the English gynecologist, advocates laparoscopy as the preferred cervical approach when available. Salpingectomy is favored over salpingectomy unless the contractor to be damaged or absent. SG and SHRE joint statement. Individuals' statement is encourage shared decision making with patients. General consensus: patient stability, reproductive goals, and facility capabilities should guide treatment. Importance of follow-up and the early detection in future pregnancies. Conclusion and the future directions. Conclusion is salpingectomy and salpingectomy are highly effective for managing both stable and emergency cases. Minimally invasive surgery such as laparoscopy preferred, the laparotomy, and the patient stability, fertility goals, and the extent of tumor damage are the choice of treatment. Which one is medical or the surgical one? Recurrent ectopic pregnancy and psychology impair remain challenges in long-term outcomes, unfortunately. The future directions: improved early detection techniques and fertility sparing options improve outcomes with women with bilateral tubes disease. Innovative medical treatments to replace some complicated some surgical management, psychological support strategies to address the emotional aftermath the ectopic pregnancies. Thank you so much, and thank you for listening to me.